Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent educational grants from Pharmacyclics LLC, an AbbVie company, and Janssen Biotech Inc., Pfizer Inc., Genentech Inc., Novartis Pharmaceuticals Corporation, Incyte Corporation, and ADC Therapeutics America Inc.
Hello, I'm Dr. Julie Vos from the University of Nebraska Medical Center, where I'm Chief ASH 2024 Highlights of Key Lymphoma Data. This four-part program will highlight important new lymphoma data presented at the 2024 meeting of the American Society of Hematology. The agenda is Chapter 1 is chronic lymphocytic leukemia that I'm going to present. Chapter 2 is follicular lymphoma. Karen Jacobson will present. And Chapter 3 is diffuse large B-cell lymphoma. Also, Karen Jacobson will present that. And Chapter 4 is Hodgkin's lymphoma. Alex Herrera will present that. First, I'd like to go over some of the highlights and some of the abstracts that were presented at the ASH 2024 meeting for chronic lymphocytic leukemia. The first one I'd like to highlight is abstract 3254, and this was initializing first-line fixed duration ibrutinib plus venetoclax in patients with CLL and overall survival outcome compared to rates with approximately age-matched European population. So this abstract looked at pooled populations of patients who received first-line ibrutinib venetoclax across the GLOW and CAPTIVATE FD studies. The number of patients in this study was about 265. Median age at randomization was 65 years. IGHV mutation status was 59% unmutated, so 37% mutated, and 4% unknown. And the median follow-up with this abstract is pretty long at 55.7 months. The overall survival was very similar for the pooled population of ibrutinib plus venetoclax treated patients and age-matched general European populations. So at 36 months, the overall survival was 95% in both arms. 48 months, it was 93%, and 60 months, it was 91%. And there was no difference at all between the two subsets. The similar overall survival estimates for older and younger subgroups of patients of the ibrutinib plus ven treated patients versus age-matched controls were identical. Similar overall survival estimates for the pooled ibrutinib plus ven treated patients based on IGHV mutation was also present for age-matched controls. So the pooled analysis of patients from the GLOW and CAPTIVATE study, what overall survival rates for patients with CLL treated with first-line ibrutinib plus venetoclax were very comparable to age-matched controls in the general European population. Comparable overall survival rates were observed both in younger and older patients above and below age 65. And overall survival rates were very similar to age-matched general European populations, regardless of the IGHV mutation status. I think this is very important information, showing that it really compares favorably to age-matched patients when utilizing this treatment in first line. The next abstract I'd like to talk about is 1855, and this is looking at early obinutuzumab, how it significantly increases bone marrow undetectable MRD4 rating when combined with acalabrutinib and venetoclax in a randomized phase 2 setting. This is for treatment-naive CLL patients. They had either a mutated TP53 deletion 11q or unmutated with complex karyotype, so higher risk patients. Looking at the ability for undetectable MRD4 status at the end of cycle 9. Median follow-up on this particular study was 29 months. Arm 1 had acalabrutinib, obinutuzumab, and venetoclax. Arm 2 had acalabrutinib, venetoclax, and early obinutuzumab, meaning that obinutuzumab was given earlier to try to decrease the tumor bulk before the other two were started. You can see that the AVO combination definitely had much earlier undetectable MRD after 4 cycles as compared to those without the addition of the early obinutuzumab. Safety of early obinutuzumab with acalabrutinib was really no difference between the 2 arms. There was a slight increase in neutropenia and infections in the AVO combination compared to the AV combination, but typically these were all low-grade AEs. Early obinutuzumab demonstrated a significantly improvement in the bone marrow undetectable MRD after 4 cycles at the end of 9 cycles and persisted through 14 cycles. They were both well tolerated. The addition of the obinutuzumab did add some toxicities with increased neutropenia and infections and infusion reactions in some patients. There were 3 COVID-19 related deaths also in the AVO arm as it was performed during that time period. The next abstract I'd like to discuss is 1867, multicenter phase 2 trial of zanubrutinib, obinutuzumab, and venetoclax, a Bowen study, treatment-naive CLL patients, 5-year follow-up. Patients in this study were CLL, SLL patients requiring treatment that were in the first line, otherwise able to uh, maintain the treatment, and also the primary endpoint was confirmed undetectable MRD4 in both the bone marrow and the blood. This was a staggered start to the study. This was enrolled in different cohorts. Median follow-up of this particular cohort now is 57 months. The median age is 62, but a wide range 23 to 77. And there were also a wide range of different types of patients with IGHV mutated or germline and also TP53 abnormalities in about 17% of patients. MRD4 outcomes in this phase 2 Bowen study showed that, um, of course, the MRD status continues to improve with time on treatment. Best MRD status in the blood or the bone marrow was quite high, was 96% in the blood, eventually due to MRD status undetectable, and 92% in the bone marrow. And these are very high numbers compared to some of the other treatments that we use. The patients who got MRD negative quickly did have more time that they stayed in remission, and this was achieved fairly quickly after the first test result. Safety profile was very good with this combination. Most were grade 1 and 2 toxicities. There were a few cytopenias that were grade 3 and a few neutropenias that were grade 4, but otherwise quite well tolerated. There was a subset of patients that were retreated with zanubrutinib and venetoclax. This was 16 patients, and it did show that you could have a second time to get MRD negativity with the addition of this as a relapse treatment. These patients had overall response rate of 92%. If they had MRD negativity in the blood, that was about 46% of those patients. So they can be retreated in some circumstances. Toxicity with the retreatment was fairly low with grade 1 to 2 infections mostly. So key takeaways from the Bowen trial was that it was very well tolerated. No additional safety signals were seen. And some patients could be retreated afterwards if they relapsed, again with MRD negativity in about half the patients. Next study I'd like to go over is 887, and this is looking at liso-cel in combination with ibrutinib for patients with relapsed refractory CLL and SLL. These results from the Transcend study. This patient population, a certain percentage had ibrutinib that was given either continuously or restarted at enrollment and up to 90 days after the liso-cel. There were 65 patients that underwent leukapheresis, and they were patients' median age was 65, and the time from leukapheresis to liso-cel available was a median of 25 days. Liso-cel with ibrutinib in patients with CLL had a overall response rate of 86%. CR or CRI was about 45%, and median time to CR/CRI was about 3.1 months. Median PFS was 31 months. Median overall survival was not reached. and there was a very high rate of MRD negativity in the blood at 86%, in the marrow of 84%. So, in these multiply heavily pretreated patients, this was considered to be very excellent outcomes. Toxicity, as we know with all CAR T products, had some toxicity with cytopenias. Grade 3 or higher lysosome related toxicity was about 57% of patients. And what was supposed to be ibrutinib grade 3 or 4 was 43%. Grade 3 cytokine release syndrome was in 2 patients, so 4%. Neurologic events or ICANS was in 6 patients, or 11%. There were about 45% of patients, or 25, that had some prolonged cytopenias, grade 3 longer than 30 days. So, key takeaways from this abstract showed that patients receiving ibrutinib during lysocell in patients with relapsed refractory CLL, SLL, this combination had substantially improvement in deep remissions and manageable safety profile, and it showed a numerically higher overall response and complete response rate as compared to single agent lysocell. It did appear actually to lower the CRS grade 3 or 4 or neurologic ICANS toxicity. And this, of course, is not a direct comparison, but does appear that this addition did not at least worsen the toxicity. So, thank you very much for your attention today. I hope you've learned something from our abstracts, and hope you enjoy the rest of the ASH meeting. Thank you.
Hello, everyone. I'm Karen Jacobson from the Dana-Farber Cancer Institute, and it's my pleasure to give you some real-time updates on some of the exciting abstracts that were presented in follicular lymphoma at this year's ASH annual meeting. So we have a lot of exciting studies to go through, so we're going to go through them somewhat quickly. The first study I wanted to talk about was a study of single-agent mosunetuzumab that was tested in previously untreated patients with follicular lymphoma. This was the preliminary results of the MYTHIC FL1 trial presented by Lorenzo Falchi. This was a phase 2 open-label study, and patients were eligible for the study if they had follicular lymphoma that had never been treated but was in need of treatment by classic symptomatic disease or GELF criteria. Patients were given time-limited mosunetuzumab according to the standard step-up dosing in the first cycle, followed by dosing thereafter on the first day of every subsequent cycle through cycle 8. If patients achieved a complete response after cycle 8, they were placed on observation. If they had a partial response, they then could continue mosunetuzumab according to the same schedule through cycle 17. And if they had less than a partial response to therapy, they came off of study. The patient characteristics were notable for a median age of 59 years. I should have mentioned that 78 patients were treated in total. There was a slight male predominance. This study did include grade 3A follicular lymphoma, and about 1/5 of patients had grade 3A follicular lymphoma. The majority had advanced stage disease. About 3/4 had stage 4 disease. About a quarter had high risk FLIPI, and everybody had a reason for treatment, as I had indicated before. The overall response rate for single agent Mosun in the setting was 96%, with a complete response rate of 80%. The median follow-up on the study was about 12 months, and the progression-free survival at 12 months was 91%, and overall survival was estimated to be 99% at 12 months. In terms of toxicities, there really were no new toxicities that were seen by giving single-agent mosunetuzumab in the frontline setting. About a little over half of patients had any grade cytokine release syndrome, but it was largely grade 1 or grade 2. Actually, it was only grade 1 or grade 2 in all patients, and the majority of patients had grade 1 CRS. The incidence of CRS was greatest on cycle 1, day 1, and then decreased with subsequent dosing. So the conclusions, or the author's conclusions from this abstract, were that fixed duration mosunetuzumab is effective as a frontline therapy for follicular lymphoma, with very high overall response rates and CR rates, and with early follow-up, what seemed to be durable responses. Treatment was well tolerated on a purely outpatient basis. I should specify that these patients did not require hospitalization for the first cycle, and there were no new safety signals. And as I mentioned before, at a median follow-up of just over a year, this supports taking this regimen forward in a comparative, potentially randomized clinical trial. We next saw another CD20 bispecific, epcoritamab, tested in combination with bendamustine and rituximab in the frontline for follicular lymphoma. This was an arm of the EPCOR and HL2 study. This was specifically arm 3 of that study, and it was presented by Josh Brody. On this study, patients with, again, previously untreated follicular lymphoma who had a reason for treatment were enrolled in an open label fashion. Patients were treated with bendamustine and rituximab every 4 weeks for a total of 6 cycles. They got epcoritamab weekly from cycle 1 to 3 with the standard step-up dosing in cycle 1. And then they got epcoritamab every 2 weeks from cycle 4 to cycle 6. And then finally, from cycle 7 to cycle 9, it was also every 2 weeks, but not in combination with bendamustine therapy. And following cycle 9, patients were continued through 2 years on Q4 week dosing of epcoritamab. In terms of baseline patient characteristics, we saw the results of 25 patients that were treated on the study. The median age was 56. This study also included grade 3A follicular lymphoma, and that comprised about 40% of the population. 52% had advanced stage disease, and 60% had a high-risk FLIPI. The top-line results of this study revealed that the overall response rate, again, was high at 96%, and all of those responses were complete responses. So again, the CR rate was 96%. And again, duration of complete response was 87% at 30 months of follow-up. When we look at that 30-month time point, it was 83% for PFS and 96% for overall survival. And similar to looking at mosunetuzumab in the frontline setting, there really were no new safety signals appreciated with this combination. The risk of cytokine release syndrome was 68%, but it was all grade 1 or grade 2, with 48% being grade 1 and 20% being grade 2. And just like we see with epcoritamab monodosing, or monotherapy, the greatest risk of cytokine release syndrome was on the day of the first full dose, cycle 1, day 15. And so I think the conclusion of this study was very similar to what we saw for single-agent mosunetuzumab, which was that epcoritamab combines safely with bendamustine and rituximab, leads to incredibly high complete response rates, and with about 2.5-year follow-up, we're seeing that these responses are quite durable. Finally, in sticking with bispecifics, we saw the first, or sort of more mature results of CD19 by CD3 bispecific in relapsed and refractory follicular lymphoma. This was presented by Dr. Howe. This was a first-in-human study, so actually involved a dose escalation portion, which then went into dose expansion. The dose escalation portion was in multiple histologies, and then the data that was presented here was a dose expansion in follicular lymphoma. Just like other bispecifics, this bispecific involves step-up dosing in cycle 1. There are 2 intermediate doses before you get to the treatment dose that are given weekly in cycle 1, and then the drug is given twice monthly or every other week from cycle 2 to 24 on the study. There were 56 patients treated on this study. The median age was 62. About a fifth of patients had bulky disease. About a third of patients were considered POD24 to their frontline chemoimmunotherapy. The median number of prior lines of therapy for patients treated on this study were 3, with more than 50% of patients having 3 or more prior lines of therapy. We saw very high response rates at 95% in the relapse refractory setting, and the CR rate was 85%. These responses were similar in patients who had CD20 negative disease, which is important because this bispecific targets CD19. And also these responses were seemingly preserved in the few patients that had had a CD20 bispecific coming into this therapy or had previously had a CD19 CAR T cell therapy. When looking at progression-free survival, the estimated 12-month progression-free survival was somewhere around 75 to 79%, depending on the dose level that was studied. So these responses, again, do appear to be durable. The most common toxicity was cytokine release syndrome, but with the step-up dosing in cycle 1, cytokine release syndrome was limited to grade 1 or grade 2. It did occur in about 50% of patients. There was one patient who had ICANS on this trial, but overall, the toxicity profile looked fairly similar to what we see for the CD20 bispecifics. So the authors concluded that this drug showed a high CR rate and was well tolerated in patients with heavily pretreated follicular lymphoma. The overall response rate and the CR rate was very high. And the responses appear to be durable at this point, and additional studies are ongoing in the relapse refractory space as well as in the frontline space. I want to briefly talk about a poster that was presented by Nancy Bartlett that looked at the pharmacokinetics and safety and efficacy of subcutaneous mosunetuzumab as it compares to the IV formulation, which is currently FDA approved. So the subcutaneous formulation differs a little bit from the IV formulation in that there's actually only one step-up dose as opposed to two before you reach the recommended treatment dose, which is actually 45 milligrams as opposed to 60 milligrams for the IV formulation. But otherwise, dosing is very, very similar. They tested this in 94 patients, compared it to 90 patients treated with the IV formulation, and were able to demonstrate that PK was similar, that response rates and durability of response was similar with the two different formulations, and that there was no difference in safety signal between the two formulations. And so the authors concluded from this that subcutaneous mosun can be taken into the clinic and replacing IV mosunetuzumab, which potentially can be of logistical benefit for our patients. Switching gears a little bit from bispecifics, I wanted to just review the CD19 CAR T cell landscape in relapsed refractory follicular lymphoma. We saw updates from the 3 pivotal studies that led to the FDA approvals of our 3 CD19 CAR T cells in follicular lymphoma. The ZUMA-5 study for axicabtagene ciloleucel, which was presented by Sattva Neelapu. The ALARA study for tisagenlecleucel, which was presented by Catherine Thiebelmont. And then the Transcend FL study of lisocabtagene maraleucel, which was presented by Loretta Nastapool. So for ZUMA-5, we saw the 5-year update. For ALARA, we saw the 4-year update. And for Transcend FL, we saw the 2-year update, all of which are demonstrating a nice durability of response, better than what we're seeing with the CD20 bispecifics as monotherapies in the space. For ZUMA-5, at 2 years, the progression-free survival somewhere between 60 and 65%. And at 5 years, it appears to be about 50%. So that looked like the median PFS of 5 years has been reached. For the ALARA study, at the 4-year update, we look back and we see that the 2-year PFS is again about 60%, and the 4-year PFS is about 50%. So again, looks like we've reached a median PFS at 4 years for Tisacel. And then for Transcend FL, this is a newer study, so we only have 2-year follow-up, but the 2-year PFS is about 72% so far. There was some interesting data presented by Sattva Neelapu regarding ZUMA-5, looking specifically at lymphoma-specific progression-free survival, because one question that comes up is, do CAR T cells cure follicular lymphoma, which has historically been incurable? And when we look at the data for lymphoma-specific progression-free survival, we see that there have actually only been 4 relapses since the month 24 mark, now through month 60, and actually only 1 relapse that happened in the past year since this data was previously presented. And Dr. Neelapu made the comment that this may potentially be reflecting a plateau in the relapse risk, and maybe we are starting to see the curative potential of CAR T cells in follicular lymphoma. And there are just 2 other studies I want to touch upon that relate to CD19 targeting. The first was a study that came out of the University of Miami by Dr. Alderuccio, which was a study of loncastuximab to serine, the CD19 antibody drug conjugate, in combination with rituximab in relapsed refractory follicular lymphoma. So on this study, patients were treated with loncastuximab and rituximab for 12 weeks in an induction, according to an induction schedule. They then underwent a PET scan at the 12-week mark, and those patients who were in response continued on loncastuximab every 3 weeks, with rituximab every 8 weeks until week 21 when they got a subsequent PET scan. And then based on their response, they either continued on maintenance if they were in a CR, they continued on the combination if they were in a PR, and if they were in less than a PR, they came off treatment. This was time limited therapy, so that last maintenance 2 course was 18 weeks long with an end of treatment PET scan and follow up. This study reviewed 39 patients treated, about half of whom were refractory to their last line of therapy. Their median number of lines of prior therapy were 1, but ranged from 1 to 6. And about a third of patients had had 3 or more prior lines of therapy. There were no unique safety signals seen beyond what you would expect for loncastuximab or rituximab. And when we look at their responses at week 12, at that first time point, the response rate was 97% with a complete response rate of 67%. But as patients continued on therapy in response, we saw the CR rate actually go up to 77%. And the estimated 12-month progression-free survival was 95%, and the estimated 12-month overall survival was 94%. So the authors concluded that limited duration lonca rituximab can induce a high CR rate, and these responses appear to be durable with a safety profile that is expected for the 2 drugs. And then lastly, I want to end with one of the late breaker abstracts which was presented by Lori Sen, which was the results of the randomized INMIND study, which compared tafasitamab, the CD19 monoclonal antibody, in combination with lenalidomide and rituximab against placebo and lenalidomide and rituximab. This was done in the relapse refractory setting. Patients had to have at least 1 prior line of therapy, and then they were randomized in a 1-to-1 fashion to either the tafasitamab arm or the placebo arm. On this study, patients were continued on tafasitamab for a total of 12 cycles, where each cycle was 4 weeks long, so about a year of therapy. Lenalidomide was dosed at 20 milligrams per day on days 1 to 21 of each 4-week cycle for a total of 12 cycles. And the rituximab was given weekly in cycle 1, and then every 4 weeks in cycle 2 to 5. And the primary endpoint of the study was progression-free survival. 548 patients were randomized to treatment, 273 in the TAFA arm and 275 in the placebo arm. Ultimately, those were the numbers of patients that were analyzed, both for efficacy and safety as of a data cutoff of February 2024. When you look at the patient characteristics for the TAFA and placebo arms, they were well balanced. And when you look at how patients have fared in terms of their previous treatment histories, in terms of responsiveness to therapy, POD24 status, whether they were refractory or relapsed, were also similar between the 2 groups. For the primary endpoint of progression-free survival, there was a statistically significant improvement in PFS for the TAFA arm compared to placebo, with a median PFS of 22.4 months for the TAFA arm and 13.4 months for the placebo arm, with a hazard ratio of 0.43. We saw similarly impressive differences in terms of PET-CR rates as well as overall response rates, where PET-CR rates for the tafalen arm were 49% compared to 40%, and the overall response rate was 84% compared to 72%. Duration of response was also statistically significantly improved in the TAFA arm compared to the placebo arm at 21.2 months versus 13.6 months. Overall survival was not different between the 2 arms, but one of the endpoints of the study is overall survival at 5 years, so we will see an update. One of the things that Dr. Sen commented on was the fact that the lenalidomide arm did less well than we would have expected from the Augment study, which was the randomized study of Rituxan lenalidomide versus Rituxan alone that led to approval in relapsed refractory follicular lymphoma of R squared. And so she went through a lot of the different patient characteristics on the InMind study compared to the Augment study, demonstrating that that there were more high-risk patients on the InMind study than there were on the Augment study. Dr. Sen and the authors concluded that the study met its primary endpoint of prolonging PFS in relapsed refractory follicular lymphoma. We are going to await some overall survival data at the 5-year mark, as well as some patient-reported outcome and quality of life data. The safety profile was manageable and consistent with expected toxicities of these agents. And this is a therapy unlike the bispecifics and CAR T cell therapy that can be administered in the community, which makes it particularly attractive. So, in conclusion, some key updates in follicular lymphoma from this year's ASH meeting is that bispecifics alone or in combination in the front line lead to high CR rates and good early PFS. For a first-in-class CD19 bispecific in relapsed refractory follicular lymphoma also leads to high CR rates and good early PFS with a reasonable safety profile. Sub-Q Mosin appears to be similar to IV Mosin in terms of PK, efficacy, and safety. CD19 CAR T cell updates continue to show the longest response durations of all therapies in the third line and beyond, with hints at curative potential. The CD19 antibody drug conjugate loncastuximab in combination with rituximab is another regimen that can lead to high response rates and good PFS in a relapse refractory setting. And finally, tafasitamab and rituximab lenalidomide is superior to rituximab lenalidomide alone in relapse refractory follicular lymphoma, but the population was enriched for a Rituxan refractory population, which needs to be considered as we continue to see these results mature. So that concludes the updates for follicular lymphoma at ASH 2024. Please join us for a recap of the updates in diffuse large B-cell lymphoma next. Hi, everyone. I'm Karen Jacobson from the Dana-Farber Cancer Institute in Boston, Massachusetts, and it's my pleasure today to take you on a whirlwind tour of updates from this year's ASH annual meeting in diffuse large B-cell lymphoma. So one of the more important updates we saw was the 5-year update of the randomized phase 3 Polaric study, which randomized patients to receive polatuzumab R-CHP versus R-CHOP. This was presented by Gilles Saul. And just to remind everybody about the trial design, patients were eligible if they had previously untreated large B-cell lymphoma with an IPI of 2 or higher. They were randomized in a 1-to-1 fashion to either Pola R-CHP or R-CHOP, where patients got a combination of therapies for the first 6 cycles, which were given every 21 days, and then 2 additional cycles of rituximab thereafter. And the primary endpoint of this study was progression-free survival. And we learned several years ago that the 2-year progression-free survival was superior in the Pola R-CHP arm compared to the R-CHOP arm by about 7 percentage points. And what we see here at the 5-year time point is that there is still a difference in Pola R-CHP versus R-CHOP, with a 5-year PFS of 64.9% for Pola R-CHP compared to 59.1% for R-CHOP, and this remains statistically significant. When we look at duration of complete response, we see very similar relationships. They did look at overall survival for this trial as well, and they do not yet see a statistically significant overall survival benefit. But I'll remind you that our treatments for diffuse large B-cell lymphoma have really improved over the past 5 to 10 years, and so it may take longer than 5 years to see an overall survival benefit. So in conclusion, this 5-year extended follow-up of Polarix was consistent with the previous statistically significant improvement in progression-free survival and duration of response for Pola R-CHP over R-CHOP, and support the use of this as a regimen for frontline patients. Switching gears, drug therapies for diffuse large B-cell lymphoma, I do want to call your attention to one study of a new CD19 CAR T-cell therapy. This is raptacaptogene autoleucel, previously referred to as YTP323. This study was presented by Peter Rydell. It's an open-label phase 2 study in relapsed refractory diffuse large B-cell lymphoma in the third line and beyond. Patients were able to receive optional bridging chemotherapy, and they then underwent lymphodepletion and infusion of raptacabtagene autoleucel with their first efficacy assessment at 28 days. And the primary endpoint on this study was complete response rate. The reason this CAR is different than other CD19 CARs is that it undergoes rapid manufacturing using proprietary T-Charge platform, which means the cells come out of manufacturing much earlier. This is felt to improve or maintain their stemness characteristics and then potentially improve response rate. It certainly improves vein to vein time, is on the order of about 14 days on this study. So patients were treated at a fixed dose of raptacabtagene autoleucel. On the study, there were 60 patients treated. They were all in the third line and beyond. The median follow-up of the study was 16.4 months. The overall response rate was 88% with a complete response rate of 65%. And when we look at durability of response, you can see that the 12-month duration of response is 54% in all patients and 69% in patients who achieve a complete response. When we look at progression-free survival, we see that the 12-month PFS is 48% for all patients, but for patients who maintain a CR through month 3, it's actually 79%. And there does appear to be a plateau in the curves that emerges around month 12 for progression-free survival. And then 12-month overall survival in this study was 83%. In terms of risk of cytokine release syndrome and neurologic toxicity, rates of any grade CRS were 44% and were only high grade in 6% of patients. Of course, we also worry about infections and prolonged cytopenias after CD19 CAR T cell therapy. Similar to other studies of CD19 CAR T cells, we see infection at a pretty high rate at 49%, but they were only significant in 27% of patients. We see that there are early cytopenias in a majority of patients, largely due to lymphodepleting chemotherapy. Many of these cytopenias resolve by month 3 with 100% resolution of neutropenia and anemia at this time point, and 92% of 92% of patients had their thrombocytopenia resolve at this time point. So the conclusions of this abstract were that this is a safe and effective CAR T cell therapy that actually has both rapid manufacturing, which means we can get the cells to the patient more quickly, but also potentially preserves the stemness of these cells and could potentially lead to a benefit overall in terms of long-term durability of response. We did see an update of the single agent glofitamab monotherapy study in relapsed refractory diffuse large B-cell lymphoma. So this was a 3-year update that was presented by Michael Dickinson. Just to remind everybody, patients were enrolled on this study if they had had 2 or more prior lines of therapy. They had to have an ECOG performance status of 0 or 1. Glofitamab was dosed in a step-up dosing, and then it dosed every 3 weeks through a total of 12 cycles. The primary endpoint of this study was the complete response rate. So the complete response rate, which is similar to what had previously been reported, was 40% with an overall response rate of 52%. They like to report duration of complete response instead of duration of any response for these studies. And the median duration of complete response was 29.8 months, with 56% of patients who achieved a complete response still in response at 24 months. They look at landmark analysis by response at cycle 3 in terms of progression-free and overall survival. They see that the median progression-free survival for patients in a CR at cycle 3 is 31 months, and the 24-month PFS rate was 63%. The median overall survival for this patient population was 45 months, and the 24-month OS rate was 75%. And I do want to call your attention to the fact that we're talking about percentages of the 40% of patients who achieved a complete response, and even fewer number of those patients who are still in complete response at cycle 3. So we are talking about small numbers. Dr. Dickinson was asked about this and said ultimately about a quarter of patients are still in response at the time of this data cut. There were no new safety signals identified in this update, and the risk of cytokine release syndrome was unchanged, was about 60% for all patients, but was mostly grade 1. and grade 2, with very few patients having grade 3 or grade 4 cytokine release syndrome. There were 2 new fatal adverse events reported, one related to COVID-19 infection and one related to acute myelogenous leukemia. So the authors concluded that fixed duration glofitamab in the multiply relapsed setting leads to high response rates and durable responses in those patients who are lucky enough to achieve a complete response. To flip gears and take a look at how these bispecifics have performed in the real world since their FDA approval, I want to take a look at the abstract presented by Taylor Brooks called the Real Bite abstract, which is really looking at real world outcomes for both FDA approved bispecifics in relapse refractory large B cell lymphoma, epcoritamab, and glofitamab. They looked at 208 patients treated in the real world. 140 of these patients were treated with epcoritamab because it was both approved first, and they did show that epcoritamab had more rapid uptake in the oncology community compared to glofitamab, which is catching up. 68 patients had been treated with glofitamab. The number of prior lines of therapy for this patient population were 3. The vast majority had a high risk IPI of 3 to 5 and were advanced stage disease. And about 30% of patients had a performance status of 2 to 4. A much higher rate of patients had prior CAR T cells in these series compared to the pivotal clinical trials, where it was about a third of patients. For the entire cohort, the CR rate was 26%, with an overall response rate of 53%. It was a little bit higher for the patients treated with glofitamab, a little bit closer to the 26%, whereas the patients treated with epcoritamab were closer to 20%. And then in terms of durability of response, we see that the 6-month duration of response for epcoritamab for patients in a complete response was 84%, and for glofitamab, it was 79%. When we look at progression-free survival and overall survival by bispecific type, it does look like the median PFS and overall survival was a little bit longer for glofitamab compared to epcoritamab, although it was not statistically significant. They did look at some key characteristics to see how they separated in terms of PFS and OS for the entire patient population. They looked at whether the patients would have been eligible for their pivotal clinical trials, whether they expressed CD20, or whether they had a TP53 mutation. What they saw is that patients who were eligible for the pivotal clinical trials did considerably better in terms of PFS and OS in a statistically significant fashion. Similarly, patients that were CD20 positive going into therapy did statistically significantly better, both in terms of PFS and OS, but P53 mutation status did not have a bearing on outcome with this therapy. In terms of rates of CRS and ICANS, you saw very typical rates. Rates were fairly similar to what we saw on the pivotal clinical trials. There were some cases of grade 3 and grade 4 CRS seen. Very low rates of neurologic toxicity, and all neurologic toxicity that was seen was largely grade 1 and grade 2. So Dr. Brooks concluded that compared to the pivotal clinical trials, this cohort was enriched for patients with high-risk features, including early progression of disease after CAR T cell therapy, and 70% of patients would have been excluded from the clinical trials. With that caveat, response rates and complete response rates were comparable between the two therapies, but lower than what was seen in the clinical trials. And that perhaps that this data would suggest that patients really do need to be CD20 positive going in to bispecific antibody therapy. Sticking with the theme of bispecifics in large cell lymphoma, I wanted to just very briefly talk about the patient-reported and quality of life outcomes that were reported on the recent phase 3 STARGLOW study, which randomized transplant ineligible patients as early as the second line with large B-cell lymphoma to either glofitamab GemOx versus rituximab GemOx. So we already learned that this study met its primary endpoint of improved PFS and overall survival of glofit GemOx compared to our GemOx. What this update and report was to report the quality of life and patient-reported outcomes on the two arms. And the most important thing to note here is that the addition of glofitamab to GemOx did not change patients' quality of life or patient-reported outcomes. It did not seem to add significant toxicity that affected patients in a negative way. The quality of life and patient-reported outcomes were largely overlapping. And then we are starting to see some combination studies of the CD20 bispecifics with other targeted therapies in large B-cell lymphoma. So I'll quickly take you through a couple of these studies. We saw this combination tested with a CD20 bispecific antibody, mosunetuzumab, compared to polatuzumab and rituximab alone in relapsed refractory large B-cell lymphoma. This was a randomized phase 2 study presented by Julio Chavez from the Moffitt Cancer Center. Patients were randomized in a one-to-one fashion if they had had more than one prior line of therapy and had relapsed large B-cell lymphoma. If they were randomized to the pola Rituxan arm, they got rituximab and polatuzumab together on day one of every 3-week cycle for a total of 6 cycles of combination therapy, and then continued on rituximab monotherapy for 2 additional cycles. There was no mandatory hospitalization required on this study. So the best overall response rate for Mos and Pola on this study was 77.5% with a CR rate of 57.5%. For the Pola arm, it was 50% for overall response rate and 35% for the CR rate. When we look at duration of response, it was superior for Mos and Pola compared to Pola, where the median PFS or median durability of response had not been reached for Mos and Pola, but was 10.1 months for Pola. And then looking at duration of complete response, we saw very similar results where it had not been reached. The duration of complete response had not been reached in either arm, but the 6-month rate was 87% for Mos and Pola compared to only 52% for Pola. We saw similar results for progression-free survival, and the median PFS for Pola was only 6.4 months. To date, there's no difference seen yet in overall survival. In terms of adverse events of interest, we saw diarrhea and cytopenias in both arms, as well as peripheral neuropathy. Obviously, only saw cytokine release syndrome in the Mosin Pola arm, but it only occurred in 10% of patients and was all grade 1 or grade 2. So the authors here concluded that fixed duration Mosin Pola improved efficacy over Pola alone in terms of response rate and CR rate, and also in terms of durability of response and progression-free survival. And it supported the exploration of this combination in a transplant ineligible population in the phase 3 ongoing SUNMO study. And then there was one other combination I wanted to talk about with CD20 bispecifics, and this was the study of epcoritamab plus lenalidomide in relapsed refractory diffuse large B-cell lymphoma. This is updated results of Arm 1 of the EPCOR NHL5 trial. So just to remind everybody on this study, it's fixed duration epcoritamab that is given for 12 cycles. Patients were eligible for this study if they had had at least one prior line of therapy for their diffuse large B-cell lymphoma. 46 patients were enrolled in this study. Nearly half of them were IPI 3 or 5 or had stage 4 disease or were primary refractory. About a quarter of patients had received prior CAR T-cell therapy. And when we look at response rate, it was 64% with a CR rate of about 47%, so not considerably higher than what we see for EPCO monotherapy in this setting. The CR rate for patients who had had prior CAR T cells was 50%, so a little bit higher than what we see for EPCO monotherapy in this group of patients. The median time to response was only 1.8 months, and the median time to CR was 1.9 months. When you look at duration of complete response at 12 months, it was estimated to be 87.5% in patients who were being treated in the second line versus 70% in patients who were being treated in the third line and beyond. Like the other studies we've shown, we really didn't see any difference in the safety profile of this combination compared to the individual components. We did see CRS, but it was all grade 1. It was largely grade 1 to 2 and 56% of patients, with very few patients having grade 3 or for CRS. And we did see cytopenias, as well as rash, somewhat related to the lenalidomide. So, in conclusion, the authors reported that this combination was felt to be safe and effective for patients with relapsed refractory large B cell lymphoma. And lastly, and I think perhaps most importantly, we saw our first time dependent outcomes looking at these agents in combination with chemoimmunotherapy in the front line from the Peter Mac Cancer Center in Australia. Dr. Minson presented their single institution study that was a randomized phase 2 study of glofitamab R-CHOP versus glofitamab Pola R-CHIP for younger patients with previously untreated diffuse large B cell lymphoma. Patients were randomized in a one-to-one fashion to either receive glofitamab R-CHOP or glofitamab Pola R-CHIP. All patients got one cycle of our CHOP, either at enrollment or before enrollment, and then continued on their experimental therapy from cycle 2 to cycle 6. For both arms, the glofitamab was dosed on day 8 and day 15 in cycle 2 after their chemoimmunotherapy, and then on day 8 of each subsequent cycle through 6 cycles, and then they were continued on consolidation glofitamab for 2 additional cycles. There were 40 patients that were randomized in each arm. They were matched in terms of key characteristics. First, they looked at toxicities, and they did not really see any significant difference in toxicities in each group, as we don't see between R-CHOP and Pola R-CHIP. There was cytokine release syndrome. It was greatest in cycle 2 when the glofitamab was started, and then decreased over time and was all grade 1 or grade 2. The best overall response rate was 100% in each arm, and the best DR rate was 98% in each arm. These responses actually did improve over time, so we can see that the end of induction response was lower than the best overall response. So you were able to get continued depth of response over time with ongoing treatment. In terms of progression-free survival, the estimated 24 months PFS was actually 86% for both the Glofit R-CHOP as well as the Glofit Pola R-CHOP. And the estimated 2-year overall survival was 92%. It was estimated to be 92% for Glofit R-CHOP versus 91% for Glofit Pola R-CHOP. And so these authors concluded that Glofit plus chemoimmunotherapy is highly deliverable to patients with need of frontline therapy for large B-cell lymphoma. Rates of CRS were low grade and actually lower in frequency than Glofit monotherapy, and that the results are very, very encouraging, both in terms of CR rate as well as in terms of estimated 24-month PFS and overall survival. So just to sum up some key updates in diffuse large B-cell lymphoma from this year's ASH, we saw the 5-year update of the POLARIX study, which continued to support Pola R-CHIP for frontline large B-cell lymphoma in IPI-2 or higher disease based on an ongoing PFS benefit, but not yet an overall survival benefit to the regimen. The newer CD19 as well as CD19 and 20 CAR T cells with more rapid manufacturing and favorable toxicity profiles are being developed and show promise in the third line for large B-cell lymphoma. And in the real world, where patients progress from CAR to bispecifics quickly, the results don't look as favorable as in the trials, but combination studies in the relapse refractory setting, either with polatuzumab, lenalidomide, or GemOx, are encouraging, but PFS is still early. And finally, we got our first look at frontline CD20 bispecifics in combination with chemoimmunotherapy in terms of time-dependent outcomes, and we're seeing high CR rates and encouraging 12 and 24-month PFS rates, but randomized studies are absolutely needed to determine if this moves the needle forward in terms of standard of care. So with that, I will end our review of ASH updates in large B-cell lymphoma. I hope you tune in when my colleague Alex Herrera reviews the updates in Hodgkin lymphoma.
Hi, my name is Alex Herrera from City of Hope, and I'll be covering the top Hodgkin lymphoma abstracts from ASH 2024. We'll start off with an abstract led by Dr. Alison Moskowitz from Memorial Sloan Kettering. studying pembrolizumab maintenance instead of autologous stem cell transplant for patients with relapsed refractory Hodgkin lymphoma who are in a complete response after pembrolizumab GVD chemotherapy salvage. So the long held standard for patients with relapsed refractory Hodgkin lymphoma has been to use salvage therapy followed by autologous stem cell transplants in chemosensitive patients to try to achieve a durable response with curative intent. But with the high degree of effectiveness that we've seen in recent years with PD-1 blockade combined with chemotherapy in the salvage setting, the authors decided to study whether or not patients treated with PD-1 blockade combined with chemotherapy followed by PD-1 blockade maintenance could lead to a durable response in some patients. So patients enrolled to the study had relapsed or refractory Hodgkin lymphoma after frontline therapy. They received 4 cycles of pembrolizumab with GVD and then proceeded to receive PD-1 blockade pembrolizumab maintenance after the salvage therapy without an autologous stem cell transplant. And results from this study confirmed that patients who received pembrolizumab with GVD salvage therapy had a high complete response rate. The complete response rate was 90%, similar to what they saw in the Pembro GVD followed by transplant study. And again, this was a study that included relatively high-risk patients, including patients who had received rituximab vedotin as their frontline therapy. And patients who received pembrolizumab GVD and got into a complete response and then received pembrolizumab maintenance ultimately had a 24-month progression-free survival of 60%. Now, this is lower than we would expect if patients had proceeded to an autologous stem cell transplant. Prior studies with PD-1 blockade combined with salvage therapy have shown a progression-free survival in the long term, upwards of 85 to 90%. So this is a bit lower, but still relatively a good outcome in terms of saving patients the need for an autologous stem cells transplant. It seems like a relatively large proportion of patients were able to remain in durable response after just maintenance without stem cell transplant. Now, importantly, patients who ultimately did progress, and there were 10 patients in this particular study that did have a progression with this approach, ultimately, 9 out of the 10 were able to get to a stem cell transplant subsequently using some salvage therapy. Sometimes it was Pembro GVD again or other salvage regimens. And so not only did a proportion of patients have a long-term durable response, but patients who did not, patients who relapsed, appeared to be able to get back into remission and get to stem cell transplant. Ultimately, an important part of this study was also seeing which patients could benefit from this approach. And it seemed like patients with stage 4 disease without a stem cell transplant really didn't have great progression-free survival, 2-year PFS of 37%. But it did show patients with stage 1 through 3 disease had a 2-year PFS of 72%. So an important study showing that patients could have a durable response without a stem cell transplant, some of them. Patients could get back into response, get to a stem cell transplant if they had this kind of, deferring transplant approach. And we learned that probably stage 4 patients were not the right patients to observe this kind of approach. Another important abstract came from Jeremy Abramson and a group of colleagues who presented an updated analysis of brentuximab vedotin, nivolumab, doxorubicin, and dacarbazine for early stage non-bulky classic Hodgkin lymphoma. Patients received 4 cycles of BV with nivolumab and AD chemotherapy for early stage disease. And in this study, where over 150 patients were enrolled, again, most of them had unfavorable disease, all non-bulky. Outcomes were actually quite excellent. There was a complete response rate of 92% at the end of therapy. And now with longer median follow-up of almost 28 months, there were only 5 progression-free survival events. And so the estimated PFS at 24 months was 97%, which is phenomenal. A phenomenal outcome without the use of radiation in patients with early stage Hodgkin lymphoma. And patients with favorable disease actually had a 2-year PFS of 100%, with unfavorable disease had a 2-year PFS of 95%. But still, nevertheless, this is an excellent outcome, integrating the novel therapies, brentuximab vedotin and nivolumab, and omitting radiotherapy in these patients with non-bulky Hodgkin lymphoma. And the overall survival at 2 years was 100%. So, really promising outcomes and something that maybe isn't necessarily practice changing in and of itself, but really sets up a future study where we can incorporate these novel agents and potentially omit radiotherapy, which can be associated with toxic late effects in these typically young patients who have early stage Hodgkin lymphoma. Another abstract was presented by Anne Lacase. It was a large study, many sites across the United States participating in a randomized phase 2 study incorporating nivolumab and rituximab vedotin into radiation-free treatment of early-stage classic Hodgkin lymphoma. This study did include bulky or non-bulky patients. Again, this study also enrolled over 150 patients. Patients received standard of care ABVD for 2 cycles, and then they had a PET scan. If a patient had a positive PET scan, rituximab vedotin was added and bleomycin was dropped, so they got BV-AVD for 4 cycles. And then if a PET scan was negative after that, they would go on to receive nivolumab maintenance. In patients who had a negative PET scan after 2 cycles of standard of care ABVD, non-bulky patients were randomized to receive BV combined with nivolumab for 3 cycles, or ABVD for an additional 2 cycles, followed by nivolumab maintenance. Bulky patients all got the 4 cycles of ABVD total, followed by nivolumab maintenance. Again, this was a largely unfavorable early stage population. A sizable minority of the patients had bulky disease. Most had stage 2 disease, nearly 90%. And the study remarkably showed that patients who had a negative PET scan after 2 cycles of ABVD and then received kind of radiation-free, novel agent-containing therapy had a 2-year progression-free survival of 100%. Really fantastic outcomes. And that was whether they were randomized to BV-Nivo or randomized to ABVD followed by nivolumab. Actually, in fact, this idea of starting off with 2 cycles of ABVD followed by nivolumab is actually the experimental arm of a large randomized phase 3 study being conducted in the cooperative groups. Overall, the toxicity profile with this study incorporating the BV and Nivo into early stage Hodgkin lymphoma, as well as the prior study by Abramson et al., it's really consistent with the known toxicity profiles of these agents. No unexpected or new safety signals were observed. So on behalf of Dr. Julie Vose, and Dr. Karen Jacobson and myself, we really wanted to thank you for your participation in today's program and for your attention, and hope you're as excited as we are about the lymphoma abstracts presented at the ASH 2024 meeting. Thank you.